So thank you very much. It's great to be here. Some of my discussion is going to be some background and context because it's really encouraging that we have some familiar faces that have been here previous years, but it's also great that there's some new faces from South African drug platform discussion and structures that it's always good to reiterate some important concepts. So I'm going to talk a little bit around South Africa as a context, some of our main issues around injecting drug use, some of the population assumptions, and then I've been asked to talk a little bit more specifically around some of the epidemiological data we have around HIV and viral hepatitis, which I will also do. So as we heard yesterday, both of these viruses share the same transmission routes, but just to put them into context, viral hepatitis C is about 10 times more infectious than HIV. And when you're infected either with one of them or both of them, they affect not only your organs, but all parts of your body. And if you have co-infection, the rapidity of the consequence of infection is increased. But what's also important to note is both of these can be effectively prevented. And also hepatitis C, as we heard yesterday, can now be cured. And HIV, if people are on antiretroviral therapy and are adherent, undetectable is untransmissible. So really we know that if you have an environment where people's rights and health are enshrined and they can attain rights and they have access to services they need, where they need them, when they need them, and provided by peers, these conditions can become no longer a major public health threat. So in South Africa, it's important to note that drug use is illegal. We've heard about the Constitutional Court ruling around cannabis, but still all of the other substances remain legal. And there's been very little explicit policy support for evidence-based interventions. It's important to note that the previous National Drug Master Plan did not explicitly support harm reduction interventions. There was no explicit recommendation for needle syringe services and opioid substitution therapy. And without the new National Drug Master Plan in place, this is still the go-to national overriding drug policy document. It is very important to note and to acknowledge and to thank the South African National AIDS Council for the leadership that they've shown in including people who use drugs as a key population and actually explicitly recommending evidence-based HIV prevention interventions for these populations. And it is also encouraging also to note that the National Department of Health has developed hepatitis guidelines and as well as an action plan, and they are very near being finalized, and hopefully financing and for the implementation is the next hurdle that has to be overcome. But also in our context, there is a very high frequency of violations of the rights to wellness, to privacy, to individual choice of people who use drugs. And we heard yesterday that actually sometimes goes to the extreme of resulting in people's death, but more frequently it prevents people to attain wellness and health. And in our context of South Africa, there may be lots of criticisms about what's happening, but we must realize that these services are new. Needle and syringe services, which include an HIV testing component, have only been operational since 2015. They've only been available in 3 cities since then, and in Johannesburg and PE since 2016. And opioid substitution therapy, in terms of maintenance, which means beyond 6 months, only started in 2017. And to date, there are no hepatitis services targeting people who inject drugs. So all of this stuff that you've heard, if you've just come in, it's important to note that a huge amount of work has happened in a very short period of time. And we've just had this critical window of opportunity with everything aligning. And yes, there have been problems, but a huge advances have been made. I like to use this simplistic framing of when we talk about populations that may be involved in behaviors that are either criminal or that are not socially acceptable. And in the context of drug use, there's the legal concept, but also there's very limited understanding. There's this view of the evil of drug use, or that drug use doesn't serve any benefit for individuals, which of course we've heard is not true. And because of that context, there's a lot of moral judgment. There's the criminalization of the person and the person who uses drugs and an associated stigma and discrimination, not only by themselves, towards themselves, but of family members and of health providers. And what that in turn does is a lot of disempowerment. It prevents people to realize their rights. It results in exclusion. From people who inject drugs, it contributes to unsafe injecting. And these are significant access barriers. And why that's important is because how we understand the population and the services we can provide is intricately linked to these dynamics. So we don't have a very good understanding of the population size of people who inject drugs, but wherever you look, you will find them. So previously, they said there were no injecting drug users. We found injecting drug users. You said they would not come to our services. If we provide appropriate services, people came. So the current working estimate is around 75,000 people who inject drugs. But again, you need to note this is a dynamic population. People start using drugs, people stop injecting drugs. People may only inject frequently. Some people may use more frequently than others. And it's very hard to estimate this number. And also it's important for people who are not familiar with our context that heroin in a range of different purities or strengths is the most commonly injected drug. But there are also other substances that are injected, particularly stimulants, so crystal methamphetamine, cocaine, and some sedatives. So because heroin and the opioid group of substances are the most commonly injected, it's important to note what is happening in South Africa. We have a very poor surveillance system, and we have no community-based data around what's happening with drug use. What we do have is a well-established historical network called SADPW, which is the South African Community Epidemiology Network on Drug Use. And what that does, it collects information from people who access substance use treatment centers. Now, I always like to think of that as the tip of the iceberg. Those are people who firstly know of the service, can afford the service or where the services are, and who are accepting of abstinence-based only services. Taking that into account, there's no doubt of an upward increase in the use, availability, and potentially associated problems of heroin, wunga, nyope, which are all the same things, just different names. And a proportion of these people will inject. So we don't have a lot of information around HIV and injecting drug use, and that's a lot of the amazing work that's happened with the people who are involved in programming. And what we try to do as we move into new areas is get better at the way that we document our work so that we can use it for advocacy and policy change. Often in our context, people cite the lack of evidence as reasons for not implementation, but it's actually not lack of evidence. It's a lack of recognition that this is a problem, that these are people, and we should care. So my goal is always to make sure we capture these stories. So, sorry, for a reason I've become very emotional. We've been working in viral hepatitis most recently because that's where the gap has been. And we couldn't work out why less than 1% of the people we found with hepatitis made it into treatment where treatment was available. And so we did a qualitative sub-study. And these are the kinds of things that emerged. Doctors are not helping you. They're oppressing you. The experiences that people have with healthcare workers are really unacceptable. People are concerned that when they're waiting for health services, they're going to go into withdrawal. They are concerned that actually if they die, it's not such a bad thing. And no one talks about the issues of viral hepatitis, so people can make a conscious decision around substance use. Again, we should not be telling people what they can and can't do. We should be empowering people with the knowledge so they can make their own decisions. So with that in mind, we now know that there are these harm reduction programs which are operating in most major metropolitan areas. They've started with the available funding, which has come from an HIV paradigm, which has had pros and cons, and it's always been an HIV prevention approach. So we've got a good idea from a programmatic perspective of what the burden of disease is from HIV. And you will see that it varies by city. And thank you very much to all the programming partners who've been very kind in sharing the information. I've just put some caveats there because I used the available data that was most easy to put into the slide. So the Reporting periods differ, so that's why you will see that the numerator and denominator in the time frame is not the same. But it's just to give you an indication of when they're working operationally, what's the prevalence of HIV that's being found among people. And you'll see in Cape Town, it's around 3%, and it goes up to as high as almost 50% in Johannesburg. And Johannesburg is particularly interesting for me because Johannesburg and Hillbrow was always where injecting drug use always was. And then people said injecting drug use is not there anymore, but there weren't any services. And as soon as Anova Health, through the funding from Global Fund, went there, they found a huge epidemic of HIV. And I know if they test for hepatitis C, it will be astonishing. So now when we look at our surveillance data, the good thing is we've now got some more robust information. From an HIV and a hepatitis perspective, there have been 2 recent studies. One of them was a key population hepatitis initiative, which was a surveillance project that was linked onto existing harm reduction programs. So it has some limitations with what you can and can't say about the data and how you can and can't extrapolate. But nevertheless, it confirms a significantly higher hepatitis C burden than HIV. And what the hepatitis initiative did is it actually confirmed virological infection. So this is not seroprevalence. These are people that are infected with hepatitis C. And you'll see in Cape Town it was 34%, in Durban it was 29%, and in Pretoria it was 73%. And then when I talked about the HIV-HCV co-infection, it also ranged between cities, but being as high as 30% in Pretoria. Recently, the University of California, San Francisco, implementing with Anova Health through funding through CDC, have done some integrated biobehavioral surveys in 2 cities, in Pretoria and in Cape Town. The report has not been finalized yet, so these are point estimates that we got approval to use. And what's good about this is it's using respondent-driven sampling, so it's a much stronger methodology. And it also includes population size estimates. And so these are estimates that when they are finalized, you'll be able to apply to the broader population, not just people accessing the service. And you'll see they found higher HIV and higher HCV and higher co-infection. What I thought would also be nice was to show some data around, also from the hepatitis initiative, of what's happening with viral hepatitis C, which is even more infectious than HIV. It's about 100 times more infectious than HIV, but it is effectively prevented through vaccination programs. And why this is important is when thinking of comprehensive packages and the universal care in NHI, viral hepatitis services, HIV and TB need to be included in that core package. We don't have any data on people who inject drugs who are on ART, so that's a major treatment gap. These are the HIV treatment cascades for people who are not familiar. What we're trying to do is to assess our response in terms of targets that UNAIDS has developed around how to potentially end the AIDS epidemic, which means that 90% of people living with HIV know their status, 90% of those are on antiretroviral therapy, and 90% of those who are on ART are virologically suppressed. And that process helps us think through any condition, TB, viral hepatitis, because what we want to see is just testing someone is not enough. We need to make sure that person, if they want to access the treatment and are supported to complete that treatment. And it's important for viral hepatitis because we can cure their infection. And you'll see there's significant drop-offs on the people who are infected with HIV to those people who are on antiretroviral therapy because there aren't dedicated treatment services for people who inject drugs. And similarly, we don't have any data of antiretroviral, at least viral suppression among people who inject drugs. So programmatic and research data confirms that HIV and viral hepatitis C are an important issue among people who inject drugs. And co-infection does occur, and it does vary by city. And part of that can be explained by the background prevalence, but also the duration that injecting has been happening in the city, as well as other practices, access to sterile injecting equipment, etc. We do have some significant data gaps, and it's important to know what's happening in the other metro areas and also trends over time, which we don't have yet. And it is important that harm reduction as an approach gets more widely adopted, but more importantly, the interventions that are evidence-based, particularly needle and syringe services, opioid substitution therapy, and also harm reduction for stimulant users and people who don't inject drugs, we need to be more aware of what's happening globally. We found that many of the people who use drugs, it's not the drugs themselves that cause an issue, and I think that's come out during the last couple of days. Often it's the context that people find themselves that actually are the major issue, and the criminal justice system is just another factor that affects individuals. So there's often a sense of hopelessness, and providing access to voluntary psychosocial services that take a harm reduction approach is really critical, and it's not widely enough available in South Africa. And as you heard from Ian previously, there have been steps to improve sensitization of healthcare workers around gender diversity, around sexual orientation, but there's still a very far way to go around harm reduction and evidence-based interventions, particularly OST and needle syringe services. And again, unless we have structural change to move towards regulation of substances, we're going to be in this situation for many years to come. And thank you very much to everyone who provided their data, and thank you for joining us.